actually the implementation of direct access is not as simple as, right, we're just going to use direct access.
I think the answer is with real difficulty. But what I would add to that is that anything that's worth doing is never really easy, and anything new is usually not easy. And so when you're one of the first people to do it, there's a lot of confusion. There's lots of uncertainty. There's a lot of focus needed to reassure the team, to make sure there's collaboration, and there's a lot of learning very quickly in terms of what isn't going well, and it has to have some dedicated focus and some endurance from the leadership that we're not going to give up on this. We believe in it, and it will come through. Because when it comes out the other end, like anything tough that you've done, it's usually worth it, and it has been for us.
How to make it work: good communication, understanding of scope, what you can, what you can't do, internal referral processes, and just a general open communication and respect for each other.
We talk about behaviour change a lot in dentistry, and it's usually about behaviour change of our patients, trying to motivate them to change behaviours. But actually, we have to do certain behaviour changes in the business of dentistry as well to implement something.
It's about talking to your team. And that's not just the clinicians, that's the whole team. Everybody within your dental practice needs to understand what it means. They need to understand what it means, what a dental hygienist can do, what a dental therapist can do, what they can't do, and also not forgetting our clinical dental technicians, what's within their scope, what could they offer to a patient who, could benefit from their care. So it's a full understanding of the scope of everybody, because it's going to be the receptionists, generally the reception team, who are going to be taking phone calls or inquiries from prospective patients. And then perhaps a little bit of simple triage as well. So not asking receptionists to diagnose or anything. What you're asking them to do, or giving them as a team, as a workplace team, questions so that they're signposted to the correct person. Because, sometimes people will get it wrong. They'll say, oh, I've got an ulcer, my mouth really hurts. And you'll say, okay, fair enough. You could see the dental hygienist or dental therapist. And when they get in the chair, then suddenly you realise it's actually not an ulcer at all. It's an abscess, and they've just conflated the two. So they're also within that, you can't plan for that necessarily. People will get things wrong or, misdirections, but then to have an internal referral process so that if that sort of situation comes up, that dental hygienist or therapist knows what to do next, and that the dentists are then happy within the practice to work in that way and take that referral from that clinician.
Within practice, I think it does have to involve the whole team with the implementation. So I think, especially speaking personally as a dental therapist, I think, having the whole team call you by your correct title, often we'll be called hygienists rather than dental therapists, so that patients know that if they are coming to you, the range of services that you can provide. I think patients need to be, informed of that before their appointment, at their appointment as well, with you of where your limitations lie. But in terms of access, reception basically just need to know what's appropriate for a dental therapist or hygienist, to be booked in with them, and what's more appropriate to be booked in with the dentist. So I think definitely, as with a lot of things in dentistry, involving the entire team is crucial for direct access.
It's having a team ethos that work is shared across skill mix in general. So not just you have to have an ethos of wanting to utilise all team members in the first instance, and that means that not only in direct access in terms of shared care, I very much see the use of dental nurses, for example, in terms of the enhanced skill in terms of impressions, taking radiographs and all that. I actually see it as a crucial thing, not just because they're doing it so that I don't have to, but actually they're doing it because it's a bit more rewarding and it retains them in the role that they have. So if you've got a whole practice that thinks actually this is something that we think is useful, that we all believe in sharing in terms of shared care. Then the next logical step is to say, well, actually, you have to have people that are willing, because I think where it doesn't work is when one part of the practice, usually the practice owner, is trying to bring someone along to do something that the other one, the person providing the care, is not comfortable with. So you definitely need everyone on side, I would say.
The ultimate thing is communication. If you want to implement direct access, you have to go and speak to the whole team. We have to make sure that, like I say, it's part of the culture, that everybody is on board and that they send the same messages.
It starts with the regulatory framework, first of all. The GDC set out clear guidelines about what treatments clinical dental technicians can provide without having to have a dentist referral. And we have to make sure that everyone understands that, is compliant with it and works within those rules. Training is crucial as well, of course. CDTs, if there's going to be a change in patients being able to have direct access, then CDTs need to be trained to make sure they can carry out the right procedures and have the right skills to do that, and understand their roles and responsibilities, and make sure they're providing safe and effective care, of course. And that, arguably, for those who are operating in a dental practice, that's easy to do, because you have on hand all the experts that you need. But for CDTs working in their own clinics, communication is key there between the dentist and the referring dentist and the clinical dental technician.
The challenges are, first of all, being clear on what can be done, which has got a whole plethora of answers to that question. So first of all, it depends on the DCP's scope of practice. And just because it's written on a GDC website, that doesn't mean that individual is comfortable in doing everything that's on that scope of practice. And so it has to be learner-led. It has to be about the individual, about what do they feel comfortable with in doing. Because there just hasn't been any focus on direct access, a lot of DCPs are going to be uncertain. A lot of them will not have done direct access at all, other than their training, which may have been years away. And so the initial steps to reassure them, to make sure that there's somebody there to mentor them and give them time, whatever's needed, to walk them through the challenging steps until they feel comfortable, is something that practices have to invest in. The additional problems that we faced when we first started to implement it is there was a lot of confusion amongst the profession. So, for example, the indemnity providers weren't sure what was supposed to be going on. The commissioners weren't sure. The software providers weren't sure. All of these things are now being ironed out. And so now it's a case of having a plan per the individual, and then really investing in it and seeing it through till they come out the other end and feel comfortable in doing what they set out to do. And so for us, it was starting with younger children that were relatively stable, that had been to the practice before, but we couldn't get them into their routine review. And so initially starting with those meant that the therapists were able to build up their confidence and then move on to older children and then potentially adults with time as well.
Unlike other healthcare systems, dentistry is a business, and therefore you have to make the business work, be it NHS or independent or private. But the big thing is that each practice is individual. No two practices are the same. It's made up of a team of people who in themselves are individual, unique setting, whether it's in the high street, whether it's a purpose-built practice, or something that's been converted to be a dental practice. So there's so many things that are involved.
We can do it for existing patients. So if the recall's been set at once a year and it's 2 years, in effect, that's a direct access appointment, just because they haven't had an examination in the set recall time. And then obviously you can get people phoning up, I haven't seen anybody for ages. And I've certainly had a few of those. They're too embarrassed by the state of their teeth to go straight to the dentist. So they want me to sort them out, and then they'll go and see a dentist when they look a bit better, which I find a bit strange, but there we go, you know.
When you make any change or any implementation, you need to have sort of 5 things. You need to have, first of all, the financial incentive, because as I've said, dentistry is a business. We all have to earn an income. So you can't do anything that's not going to be of benefit to the business.
The nitty-gritty of pricing, that depends on your business model. That's a conversation to have with your clinicians.
Dentistry is difficult because not only is it a business, but it is also has professional responsibilities as well. You know, we have to do the right thing for our patients. We shouldn't be led by financial gain. So even if you perhaps not making a financial gain as such, it has to be cost neutral, any change you make. So it may be you're making a change for patient benefit or for work-life benefit, but it can't cost money. So you have to have the right financial incentive to be able to make any sort of intervention.
There is probably a need in some areas for the patient to feel like the link that they have is with the practice, is with the entity that is the practice, as opposed to one individual person within that. Now, having continuity of care is really important. I think that's still positive, but you can still have continuity of care through direct access as well as shared care. It's just how you set it up. So from my perspective, I think it is all about the culture that you set within the practice, whether you've got the ability to really, I think, empower the team to do things that they want to. I think what I would always say is it isn't for everyone. So I fully understand those that don't want to do it. And I don't think anyone should be encouraged, coerced necessarily to do it beyond what they really feel comfortable with. And I think that's absolute key.
You need to have the right practice culture as well. And practice culture is, you know, it's complex in itself. But if you don't have the right makeup, so if you don't have the right team involved, so in terms of, do you have the correct skill mix to make this work? You may have a couple of dentists, a couple of hygienists or therapists, but if you don't have enough nursing staff to support that, then that's not going to work. If you don't have reception staff, if you don't have the right idea of wanting to implement skill mix or role substitution and direct access, then it's not going to work, and all team members need to be on board with that.
I think some of the key points for how direct access can be implemented is firstly making sure that practices update their protocols to include direct access, sitting down and agreeing what the patient pathway may look like, ensuring that the hygienists and therapists are competent to work within their scope of practice and how the team can help support that. And then ultimately just having really effective communication and patient education is then really going to help make that very seamless.
There's got to be clear protocols to make sure that direct access works. When a patient needs to be referred back to the dentist, whenever there's any underlying oral health conditions, of course, the patient needs to be sent back. And that means that it allows clinical dental technicians to get on, provide the care efficiently, but also ensuring, because they've looked and they've carried out dental examinations or treatment, that treatment gets carried out by the appropriate professional. Education and continuous professional development are crucial for this to work properly. As the role of a CDT evolves, so should the training, of course, and as direct access evolves, so the training, whether that training is via places like where I work, academic institutions, or whether it's by the College of General Dentistry or other professional bodies, we need to make sure that the relevant training is in place so that direct access can be implemented easily.
It needs to be clinically led. So if it's not led by the practice principal, the practice owner, then any hiccups and any little bumps in the way of implementation won't be addressed.
I know loads of people who've opened their own practices because of this, which is fantastic. You know, it's fantastic for the profession to have that. I mean, they're never going to become millionaires overnight, and they're never going to reap the rewards that a dentist can reap financially. But they have their own business, you know, and they have ways of being able to, as I said, bring the profession on a little bit more and give patients that access they need.
I don't advertise direct access, but it's on the practice website, just pointing out that patients don't have to see the dentist first. So if patients phone up, they're offered a direct access appointment if it's applicable. You have to have a consent form, and they have to understand that there's restrictions in what you can do, and it may well be that you find things that need to be referred to a dentist. So they have to understand that they're having a more limited examination, possibly, and that you are limited in what you can do.
But I do understand there are people there that may not have the confidence to do it, and would much prefer to have a referral from a clinician to say steps and a treatment plan. I know there are people that are doing that, but I think the majority of people actually love the fact that they can be slightly autonomous for this.
Keep in mind that direct access isn't mandatory. You can't make somebody work in that way if they really don't want to, or they don't feel confident or comfortable to. But it can be a practice builder, and if you work well with those clinicians, then it could be really beneficial.
So I like this question because I feel really fortunate being able to I work in both kind of spaces as a private dental hygienist, and also I provide NHS dental therapy. So how we've been able to incorporate it from the hygienist perspective, you know, I get my patients to complete a form just to let them know that I am working under direct access. It's a private procedure, and if I see anything, you know, I will obviously refer it back to the dentist, but always encouraging our patients to still have a full exam. But the way it's evolving right now is that we can still do the full exam anyway. If you are trained and competent as a dental hygienist, you can still do that full dental exam. So I always do a base charting for my patients anyway, so we know what teeth are present and what the dentition is like, and so it just works well in that space. And obviously I get them to sign consent. For me, within the NHS, we work being literally, like I said before, the first point of contact for our patients. So I can, and I have many colleagues that work as within direct access on the NHS, so they can do the dental exam, open the course of treatment, do the exam. If any necessary treatment is needed within our scope, then we will provide that treatment for them. Anything that is beyond our scope, we have a partnering dentist that we work with, and then we would refer them over to that dentist to complete any additional treatment that may be needed for that individual on the NHS.